from Egypt. He's going to talk to us on advanced glaucoma monitoring and follow-up, a very, very difficult topic for all glaucoma consultants, because monitoring and advanced glaucoma is something that all of us are forever looking at.
Thank you very much for inviting me here to present about this topic. What I'm going to talk about today is advanced glaucoma monitoring and follow-up. Why this group of patients are so important? Simply because it affects a broad array of daily activities with various socioeconomic and health challenges, such as stigmatization, underemployment or non-employment, increased morbidity and mortality, and even increasing risk of driving accident, falls, as well as mental and health difficulties, including even depression. If we look at this graph, we could see in the United States, for example, that the cost of glaucoma management in advanced cases is 2.5 thousand up to, as compared to half to 1,500 a year. And most of this cost goes for the surgeries in the advanced cases, and in addition to the low vision aids. From the epidemiologic aspect, a significant proportion of glaucoma patients are presented too late in advanced stage of the disease. For example, in UK, 38% of cases are presented while in advanced stage of glaucoma. In South Africa, for example, 45% of patients with glaucoma are presented while they are blind at least in one eye. What about the underdeveloped and the developing country? What should we know about this advanced glaucoma? We should know the definition, how to diagnose, how to follow up, what's the target intraocular pressure in these cases, how to treat, what kind of surgery are we going to offer, but this is away from the scope of this presentation. For the definition, we shouldn't stick that much to the golden standard, perimetric definition of that version, the Anderson criteria, but we can redefine the advanced glaucoma as those with near total cupping of the optic disc, with or without severe visual field loss affecting central 10 degrees of fixation. Here is that version, the Anderson criteria, all of us are familiar with. What are the challenges in advanced glaucoma? We have challenges at different levels, one at the level of diagnosis, and the other one at the level of the follow-up, and the other one at the treatment option. How can we detect the progression? Detection of progression in glaucoma is not simple like the early and moderate stage of the disease that we can follow up with the different machines, including the imaging modalities and the visual fields, because in advanced stage of disease, the picture is different, and the disease progression didn't follow a simple linear progression, rather than it goes through an exponential model. So what we are going to concentrate with is to see the patient's symptoms and review its patient symptoms, identify secondary causes of it presents, monitoring the optic nerve structure and the functions, imaging devices, and how are we going to use it, and visual field changes. How frequent should we see this patient? Simply, patients with advanced glaucoma require more visits than other cases of glaucoma. Usually, we have to see them every 3 or 4 months, or even earlier, as deemed necessary if they have other risks. If we have to listen carefully to the patient and to pay attention to every word from his mouth, because simply subjective assessment of advanced glaucoma patient visual function is often the most important indicator of disease progression. Usually the patient is telling that their vision is getting dim and need more light, and they are unable to read. They are getting more difficulties in their daily activities. They couldn't see part of the words, they couldn't see the next line, they are booming into things more often than earlier, and sometimes there's a drop in the measured visual acuity. Also, they might experience transient visual loss. If we are going to assess the optic nerve, we should look it in a different way a little bit, because simply we have lost most of the new retinal rim, and only very thin part of the rim might be present. Most of the advanced glaucoma cases are 0.9 cup disc ratio, so nothing to be seen simply with the eye, but we might use the spectral domain OCT, but not in all cases, but in parts, while we have still remaining retinal fiber layer thickness away from the roofing effect. If we are going to examine the optic nerve, we should carefully look at the disc hemorrhages that develop, especially at the margin, as it is an indicator for disease progression, and we should know that it is transient and it vanishes simply. Also, if we are examining the optic disc, we should look for the zoom beta peripapillary atrophy, because with disease progression, it increases. As you could see here, if you look at the cup disc ratio in these cases, it is nearly the same. But if you look at the peripapillary atrophy, it is enlarging, as you can see here. If you are using spectral domain OCT, some people could claim that it is more specific, but it's not like this. If we look at the structure integrity of the optic disc and retinal fiber layer, in these cases, both of these cases, it looks the same, but if you go to the function, it's totally different, because the left one has less damage than the other one. If we have a hemifield defect, simply we cannot use, if you could see here this inferior visual field defect, there's completely loss of the retinal fiber layer here with the roofing effect, and nothing to be followed up later on with the spectral domain OCT. But the other half of the visual field is nearly normal with normal retinal fiber layer. So we can use the spectral domain OCT in such cases in following up the non-roofing part of the retinal fiber layer. Also, if we are going to use the ganglion cell count, it is not successful enough, because early in glaucoma, most of the ganglion cells are lost, but in advanced stage of the disease, we have a roofing effect, and no much ganglion cells are lost to be followed up here. But the visual field is the most important part, in addition to the clinical examination of the optic nerve and the visual, the patient symptomatology. Visual field might be the only possible way to follow up with in advanced stage of the disease. Central 24-2 might not be longer very sensitive to detect subtle changes in the optic nerve head, because of the less number of points in this big area of the visual field, and the wider space between the points. That's why if we have to follow up such a patient, we should spend that much time with the central 24-2 and losing time for getting no information, because most of the peripheral field is lost. And most of the remaining part of the visual field is the central 10 degrees. We have to resort to examine the central 10 degrees of the visual field, and we can use size 5 instead of size 3 if no information is we get with the size 3. And sometimes we resort to examine the cardinal points around fixation, or use the quadrant total sensitivities. For example, if we have to see here in this graph, the central 24-2, okay, just a moment, 24-2, we only examine 12 points in central 10 degrees instead of the 68 points with 2 degrees apart distance in the central 10. If you examine this patient with the center 24-2, you hardly see any defects here, but if you examine the central 10 degrees down, you could find the defect in the points which lies in between the examined points in central 24-2. Also, sometimes if we couldn't see any visual field island to be followed up in central 10 degrees with stimulus size 3, you could use the size 5 here to get more information to follow up. Also, the quadrant total sensitivities, we could use it for further follow-up, or use point-wise comparison or the cardinal points for subsequent follow-up for such a patient. The challenge is for advanced glaucoma, we all know that we need low target intraocular pressure and a lot of things to be followed up here. That's why it's very important to manage these cases and with aggressive lowering of the intraocular pressure. And whenever a patient appears with lower office visit measurement of intraocular pressure, progression of the disease, with progressive disease, the fluctuation should be considered in such a cases. Thank you very much for your kind attention.
Thank you, Dr. Mady, for that wonderful talk about management in advanced glaucoma. As we all know, glaucoma is a very complex disease, so we need to know some guidelines as to how to go about it, managing that, and to